for being brief, and we will have one more online presentation, Multidisciplinary Strategies in Trauma of the Periorbital Area from Planning to Reconstruction. Olga Denysiuk, the floor is yours. Dear colleagues, I am Olga Denysiuk. Today we are having my online presentation on multidisciplinary approach to the orbital trauma. Over these 4 years of war, we were able to assemble the multidisciplinary team that works as a united system. We exchange experience with the rest of the world. We are some of the best surgeons in the field of trauma, and here I am quoting Stuart Saif. We are not only a Ukrainian team, we are an international team. We are able to exchange experience. We are able to help our military. So this is Stuart with us. And when we deal with combat injuries and face trauma, the mechanisms of it are quite complex. First, among all the persons injured, about 1/3 require face reconstruction. And this is something complex because we have to do the reconstruction of the bones, of the skin structures, of the eye itself, and work with the post-op and the blast trauma scars. And scars are a difficult part of our work. So what are we able to use these days? We are able to use modern-day technologies, 3D printing, printing the individually adjusted implants for the optimal reconstruction of the bones of the skull that we can later use to reconstruct the eye structures. We use the support of our colleagues, plastic and neurosurgeons. We are using all the modern techniques and technologies. So orbital implants, we are restoring the volume of the orbit, after which we are sending patients to the prosthetic specialists to ensure a full rehabilitation of our military. What are the components of our multidisciplinary team, or MDT, as they call them in the US? So these are skull and face surgeons, neurosurgeons, plastic surgeons, dermatologists, etc. It's a big team of people helping us address trauma properly, because blast trauma is a complex issue and it has lots of aspects. And to ensure psychological and social adaptation of our patients, because we, of course, can close the wound, close the injuries, etc., if they are on the limbs, for instance. But the face is something that other people notice in the first place, and this is what causes our patients suffer. Even when they look in the mirror, they do not see the person they were before. What do we use right now? We use 3D printing to produce patient-specific implants. We do 3D computer tomography. We are forwarding this to the bioengineering and 3D printing company. They use Titan. They use this special plastic intended to restore the skull structures. They print the part of the a bone that is missing, and in cooperation with the surgeons, we are selecting the most optimal plate. Previously, they were quite big, and even with the optimal shape, we did not get sometimes what we intended to get. But here, we are optimizing the shape and size. This is one of the operations we did to reconstruct the lower orbit wall. And here is one more uh, friend from the US, the MedCAD company. They delivered to us the fabricated models, restoring the jaw structure so that our patients can speak it and have the normal life. Also, there is a Ukrainian 3D printing company that has contributed to 1,000 successful operations. So right now, Ukraine is the leading country in the use of such implants. We have the highest number of patients, the highest number of such implants used, and they ensure optimal post-op result. Here you can see the patient and patient's CT. Once the patient-specific implant has been installed, as you can see, the lower and upper walls of the orbit were subject to reconstruction, and we can see the way this looks like. There is no napalm, there is asymmetry, and the scars can be addressed over time. So what we are especially worried about are the dense areas in the eye, and we are especially careful about the reconstruction of the lower wall of the orbit. How do we get ready? And also, there was primary reconstruction, which was insufficient. Some large patient-specific anatomic structures were used. This is an example of the patient. The structures are much smaller and more delicate. We are using his own bones from the skull, from the fibula, to get the optimal results. So the patient now has a symmetrical look, and this contributes to good subsequent rehabilitation with the use of eye prosthetics. So, once we have prepared the bone structure, once we have prepared the basis, we need to prepare the orbit. When evisceration or enucleation is happening, we need to establish the orbit to the extent possible, ensuring the stable foundation for further reconstruction, and ensures the adequate movement of the eye and of the prosthesis in the future. We keep the muscles active to the extent possible. It's very difficult to identify whether the patient is using a prosthesis. Here is a patient that unfortunately lost an eye, and there was evisceration performed after the injury rehabilitation is going on well. After that, the prosthetics are being installed, and actually the technique is quite simple. We are copying the shape of the orbit that the artists draw. The eye, some patients choose to have eyes of different colors or have the trident on their pupil. This is the temporary prosthesis, and this is the way the patient looks after the operation. He is smiling, he's playing with our colleague Dmitro. So this is not the permanent prosthesis, but the patient was able to choose the color. And the patient is able to smile, and this is an example of the patient in whose case the reconstructive surgery is not necessarily helpful. So we do the scanning. We are attempting to use special bone implants with the skull and face surgeon support. After which the anaplastologists do their work. They make the external prosthetics. We are not there to force the patient to have 5 to 10 surgeries to restore some of those structures. It's not always fully humane, and this is why we are installing an exoprosthesis. You can see several steps of this happening. It's unfortunately a situation in which the patient lost both of his eyes. So we are intending to make a prosthesis for both eyes. As you can see, he already starts to look better. And now we can see the process of the endoprosthesis being created. We are doing our best to produce something looking as best as possible, as similar as possible to what he could look like. Now, finally, the patient is starting to smile because other people are finally responding to him well, and this is why we are doing all this. We are working to restore our patients' confidence. And this is an example of a multidisciplinary approach, a patient who got trauma, a patient who from the very beginning had imperfect surgery. There were some defects left after the initial surgery. There were some scars. So there were lots of efforts done. And as you can see, there are different steps of rehabilitation. She's still having ptosis in this final step of our interaction. And this is the way she looks like after the operations. We had to remove the sutures that were quite aggressive ones and not suitable for the face. There was reconstruction of the upper lid with a free flap and creation of the upper lid fold. There was Miller therapy, and instead of some additional cuts, some hair was transplanted to her eyebrow, and this restored her look to the extent possible. We also always start from the reconstructive rehabilitation. We do what is necessary to restore the bone structure. Then we proceed with the static rehabilitation. We are doing our best to reduce the number of scars and get the result as symmetrical as possible. So the aesthetics is the foundation of confidence for our patients, and this entails psychological rehabilitation, and our patients are able to smile and adapt to the realities of civilian life. And finally, we need to mention that the multidisciplinary team is the key to achieving result for our patient. Never be afraid to ask for help, because the multidisciplinary team is what ensures the best result for our patient. Thank you for your attention.